Hello everyone, I'm David Jarrom. I'm Principal Researcher at Health Technology Wales, and today in this short talk I'm going to give you an overview of health technology assessment. So what I'm going to cover in this session is what are health and care technologies, what do we mean by health technology assessment. We're going to define something called a value proposition for a technology and why that's important. I'm then going to touch quite briefly on the methods we use to identify relevant evidence for a health technology assessment and the different types of studies and the different types of evidence we can use in this work. So firstly, what do we mean by technology? Because in this field, technology has quite a different meaning to the meaning that we might use day to day to describe, particularly technological things like a smartphone, etc. It can encompass those, but it's a much wider definition than that. And it really covers any intervention at all that's involved in preventing, diagnosing or treating conditions in health and care. Also anything that can be used to promote people's health, provide them rehabilitation, or it can also be wider things that can be used to organise health and care delivery, for example, ways of delivering services. This definition is taken from the HTA glossary. There's a link there to that, and this is quite a useful resource if you're interested in more of the terminology that's available in this field. Health Technology Wales is a body that assesses all types of non-medicines technologies on behalf of health and care in Wales. We don't cover medicines because there's a separate established process for that in Wales already. But what we do look at is anything on the list below, and it certainly isn't even exclusive to the things on the list here. It can be any type of medical device. It can be diagnostic tests, different ways of doing surgical procedures, ways of organising or designing services, things like psychological therapies and different ways of delivering those, or broad changes to ways of working and ways of managing or delivering care. And just to give you, a slide with a few examples on, working perhaps through from the simplest at the bottom, the yellow stress ball there. We have done an assessment of looking at using stress balls for people, and we have done some health technology assessment work on that, through to these days a lot of our work is on things like apps on your phone, or say on a member of staff's phone, either used in isolation by the patient or perhaps used by staff to collect data from a patient in conjunction with something like the smartwatch that you can also see there. Perhaps more traditionally, something like at the bottom there, a continuous glucose monitor used by people with diabetes to monitor and assess their blood glucose, through to big expensive pieces of kit, either one-off individual pieces of kit for individual patients, such as the prosthetic limb you can see there for people who've had an amputation, through to big pieces of diagnostic kits such as the scanner that you can see on the top left there. And these are all examples of things that we could and have looked at in the past as part of health technology assessment. So what does this term health technology assessment mean? Well, I mean, this is about as succinct a definition as you can get, really. And I appreciate it's still not that succinct. It's the systematic evaluation of the properties and effects of a health technology, addressing the direct and intended effects of this technology, as well as its indirect and unintended consequences. And importantly, in terms of the context of what I'm going to talk about today in particular, it's aimed mainly at informed decision-making regarding health technologies. I'm also going to talk about how HTA is conducted by interdisciplinary groups using explicit analytical frameworks and a variety of methods. And I'm going to give you some examples of the groups we work with and the methods that we use as well. And again, this is from the HTA glossary. So again, the same link there if you're interested in reading more of this kind of thing. So this is an overview of the sorts of things we would consider as part of a health technology assessment, and broadly term, as it shows in the middle, considerations of the value of a health technology. But it's methods we use, but they're applicable to a lot of ways that other HTA bodies in the UK or around the world do health technology assessment as well. So firstly, we'd look at things like defining what's the health problem that we're interested in, what's the problem in health and care, and kind of interwoven within that, how does the health technology aim to address that? How does it aim to try and make this problem better? So those two things go very much hand in hand. We'd then look at, okay, we have a health technology and a problem it aims to solve. How effective is it at doing that? Where we use the term effectiveness, it's very important that we look at things not in isolation in how well the technology works, but how well does it work compared to what's done at the moment? Is it better than what's done at the moment, what we often refer to as standard care? We then look at something like, we then do some form of economic analysis often, or looking at the cost of introducing the technology. And again, that needs to be compared to what's done at the moment and how much that costs. We then also consider what we call organisation issues or organisational issues. This encompasses all sorts of considerations about what we might need to consider if we decide to adopt or implement this technology. Would staff need more training, for example, in how it's used compared to what's done at the moment? Is it more complicated to use? Does it make care simpler to deliver, on the other hand? Might it change the kind of staff we need to deliver people's care to address this problem, to address the health problem that we started with? And lastly, but certainly not least, what are the patient issues we need to consider? What do patients think about the health problem that we're looking at? How does it affect their lives? And if we brought in this new technology, then how might that change things for them? How might it affect their lives? How might it make things better? But also, are there any challenges to using? Is, where we are talking about particular technological things, are there any challenges to that? And are there any difficulties patients might have in using the technology? So why do we need health technology assessment? Well, as we're all acutely aware, health and care providers like NHS Wales and the NHS in the UK more widely have only got finite resources to provide care. And as the second point says, really, this is a way of demonstrating that what we're doing is value for money, that we're using that money prudently. And by doing that, we need to make sure technologies have enough benefit to justify the cost of bringing them in. Going back up a little bit though, although even if there was unlimited budget, even if we had all the money we wanted in healthcare, then we still wouldn't want to pay for products that aren't effective or are unsafe. Something could work well, but it could have really quite serious side effects, for example, that the patients may not tolerate or may not want to tolerate. And so HTA is a way of making sure we take all those considerations and use them in informed decision making. Where we do that, hopefully, the aim of HTA reduces variation. We're a body that aims to look at things once on behalf of health and care in Wales, with the aim of putting out guidance and advice that we hope reduces variation in provision of care and provides better equity of access, for example. And likewise, doing things once via a body like ourselves hopefully speeds up adoption and aims to get technologies that we can prove to be effective into the NHS as efficiently as possible. Okay, so another diagram describing our in-house process at Health Technology Wales that I'm going to refer back to a few times throughout the remainder of this talk. This again is fairly generic to how health technology appraisal is done in other bodies, so I'm just using ourselves as an example here. I guess there's probably a term I need to define in here, which I'm going to talk about first anyway, which is topic identification. Topic is just a term we use to describe any technology or any research question that people come to us with. Really important to say that anybody can suggest a topic or a technology that they think requires our work to us. that's anybody, including yourselves, can go onto our website, fill in a simple form that should only take 10 or 15 minutes if you think there's a problem that we need to look at, or a technology on which you'd like some advice. So once we've identified those topics, we then look at something called topic exploration, and produce a topic exploration report. And I'm going to start by explaining what that is. So topic exploration is a high-level search to determine the availability of the evidence. It's not a systematic search. It's not designed to be fully rigorous. It's relatively quick to give us an idea what level of evidence is out there, basically, and to answer the kind of questions that I've got here on bullet points. So what evidence is there on the technology or the way of working? What is done at the moment? What's standard care? Again, referring back to that term at the moment. And is there evidence that allows us to compare this new option, this new technology to that? How robust is this evidence? Could we use it to inform a fuller, more rigorous assessment? Are there any gaps in the evidence? And are there any other uncertainties? And this is all written up in a topic exploration report, which we then use also to start thinking about whether there's a clear value proposition for this topic of interest. I'm going to show you a couple of examples of a topic exploration report, and then I'll come on to what I mean by a value proposition. So there's a couple of examples here, and you can find lots more on our website. There's a link at the end of these slides where you can find our library of these. These reports are typically a handful of pages long, perhaps 10 at the most. They start with a one-page summary, then there's a short summary of what we know about the technology of interest and what it does and how it aims to address a problem in health and care. We then provide an overview of the evidence we found, any gaps and uncertainties in that evidence, and there's then an annotated bibliography at the back of the report for people who want to go away and look at the sources themselves in more detail. As I'll go on to describe a little bit more, findings from these and the reports are used to inform selection of topics that we think are suitable for fuller appraisal. Regardless of what happens, regardless of whether we stop at this stage in the process or go on to do fuller appraisal, all these reports are published on our website. So coming back to this term value proposition, then what do we mean by this? So we need to provide a clear and credible set of evidence-based claims on how a technology provides value to healthcare providers and users. And we do this by addressing something like the question I've got below. What would the health and care system and people who receive care gain by adopting the technology? So we're moving from simply thinking about how well does this work? Does it work? Does it do what it's intended to do? To what does it do? What's the value of that? And how does that compare to what's done at the moment? How does that compare again to standard care? And how well does it do it in isolation, but also how well does it do it in comparison to standard care? And drilling down into the detail of that, we'd start to think about things like exactly what outcomes are changed by the technology and who benefits from those. Are they the most important outcomes? Are they the outcomes that matter to people who have this condition and the people who are involved in their care? What does it cost to implement it? Not just to buy it, but overall, what does it cost to the system? It could have downstream savings, for example, if it avoids the need for people to have more expensive care in future by diagnosing a condition earlier, or it's just a cheaper option than what's done at the moment. There needs to be evidence to support all this, to support a value proposition, or it needs to at least be possible to generate this evidence. So I'm going to use our glucose monitor now as a case study in this, and talk you through firstly sort of how we would come up with a value proposition for this, and then talk through how we did health technology appraisal on this particular example, which is continuous glucose monitoring in pregnancy. So specifically, we're talking about pregnant women with type 1 diabetes here, and they're at greater risk of experiencing complications during their pregnancy, and their babies are also at more risk of complications or indeed of being delivered stillborn. We know that good control of glucose during pregnancy can avoid some of these harms and reduce them. This is traditionally done, though, via something called self-monitoring of blood glucose. Traditionally, you monitor glucose by taking a drop of blood, stabbing yourself in the finger to get that blood several times a day, and then dropping that into a glucose monitor that gives you a reading. This is obviously cumbersome and painful for patients to do. It can also be quite stigmatizing to be, if you're out in public, stabbing yourself in the finger. And so understandably, understandably, patients don't necessarily like that. It's not always reliable as it could be. Continuous glucose monitoring involves wearing a small sensor on the arm instead that's there all the time. It's relatively non-invasive and not painful to wear. And it provides blood glucose readings continuously and allows them to be monitored continuously. The aim of this is to try and result in better glucose control. And when we started this appraisal, we knew from some of the evidence that already existed that there was suggestions that this could reduce babies needing intensive care or longer hospital stay after birth. So translating all that into a value proposition would be something like, in pregnant women with type 1 diabetes, continuous glucose monitoring improves glucose control, resulting in less likelihood of neonatal complications and reduces the need and duration of neonatal ICU. So we've got a clear outline there of what are the potential implications of this, what outcomes are we interested in, tighter glucose control and less complications for babies that have been delivered by women with diabetes. And then we're also bringing in the potential cost saving element there, in that if we can evidence that there is a reduction in the need for intensive care stay for babies, then obviously that kind of care is expensive to provide. And if we're reducing the need for that care, there's potential cost savings in delivering this. Again, it's not explicitly said here, but this is all compared to what's done at the moment. So compared to delivering this, usually via self-monitoring of blood glucose. Okay, so where we've gone through this initial process and decided there's a good question that we can answer here and enough evidence to look at it, we developed something called a protocol. A protocol has also got a research question within that, and I'll give you an example of exactly what that looks like in a moment. What we're doing here is aiming to limit the evidence review and sum up its aims precisely. You may be familiar with this terminology from individual trials, which often, again, set out with a protocol to say, this is exactly what we're going to do, and we're going to say upfront what we're going to do so that we limit bias in how we do it, and we're explicit in what we're going to do, and we can't change our minds consciously or unconsciously on the way through. The aim here is really to, in practical terms, to dictate what evidence we do choose to include and what we don't. We often define that around the kind of things I've listed here, like who are we going to include, what sort of population, what are we going to include, what's the intervention, as it's sometimes called, or the technology we're interested in assessing. Again, what are we comparing it to? That would usually be what is standard care in Wales at the moment, or in the UK more widely. And then how do we measure effectiveness or value? What outcomes are we interested in? How are we going to clearly define those outcomes, and how can we best measure those? The sorts of questions we would consider at this stage. And for continuous glucose monitoring, again, our research question would be, and indeed was for this appraisal, which is a real example, what is the clinical and cost effectiveness of continuous glucose monitoring in pregnant women with type 1 diabetes? So we've laid all this out, we've decided what we're going to do and how we're going to do our appraisal. We then go on to do our evidence review and produce what we call our evidence appraisal report. So to do this, we need a process of identifying all the relevant evidence. This is done in two stages, really. First, we need to search for all that evidence and identify as much of it as possible. And so that involves specialist staff carrying out a literature search. We then do what's called a process of screening or sifting the evidence, basically going through sometimes hundreds, sometimes thousands of articles, systematically trying to identify all the evidence found in the search that we think is relevant. And we really are sitting down there with the protocol and ruling things in and ruling things out according to the terms we've defined in that, and trying to reduce any ambiguity in that as much as possible. Again, you may be familiar with this kind of the starting stages of systematic review. We use another type of evidence review called rapid review. They are similar, but as the name suggests, rapid review is quicker and less resource intensive. Systematic reviews are very comprehensive, but they are long and expensive. They can take years sometimes to complete. They can be out of date by the time they're done, essentially. Cochrane reviews are a good example, but again, interestingly, Cochrane reviews are moving to perhaps using more rapid methods for some of their work as well. Rapid reviews are faster and less resource intensive, and there's a number of ways of making sure you do that. The examples I've given here are around, making sure that we're focused and quite relatively narrow in terms of the amount of stuff we try and cover within a review. So we might do that by limiting the type of evidence we look at, or only looking for evidence on a certain number of outcomes, for example, simplifying the type of analysis that we do. And hopefully by doing this, the process only takes months rather than years. We may not cover every last bit of evidence, but hopefully we find 95+%, and we're covering all the evidence that is most important to decision making. So again, there's a trade-off there between, being fast and being as rigorous as we can, and we use rapid review to try and get the best of both worlds. Once we found all our evidence and started to compile it, we need to have some sort of process of critical appraisal. So what do we mean by critical appraisal? There's a few different definitions here. There's this quite long definition to start with from the Dictionary of Epidemiology. It's the application of rules of evidence to a study to assess its validity of the data, the completeness of reporting, what methods and procedures it uses, what conclusions it draws, and its compliance with things like ethical standards, for example. At the other end of the scale, much more pithily, there's this definition from Trish Greenhalgh, which is simply the science of trashing papers. This citation here, How to Read a Paper by Trish Greenhalgh, is a great primer on the kind of things I'm talking about, and I'd really recommend that to anybody who wants a bit more detail on this. It's one of the sort of the classic primers on evidence-based medicine, really. I guess somewhere in the middle, my definition that I'd often use is we're trying to answer this question: how well conducted are the studies used to generate the evidence, and how certain can we be about their findings? Again, certainty is a word that I use to try and think about, well, if we did this study all over again, might we find a different result? Are there things here going on in the background? Are there types of bias or unintended consequences that might be hiding the true result? I don't have time to talk about critical appraisal in detail, but I'm just going to talk about the types of studies that we often look at in the field of health technology assessment. And these are roughly in kind of priority order, but it's really important to emphasize that there's increasingly acknowledgement that it's not just a hierarchy with systematic reviews at the top and observational studies at the bottom. All of them have their advantages and disadvantages. Systematic reviews, with or without meta-analysis, are a way of summarizing and analyzing a number of different studies on the same topic, and we can use or reuse some of their findings rather than starting all over again. Really important to emphasize that only as good as the evidence they report. So authors of these types of reviews should be upfront about the quality and the certainty of the studies that are included, and any uncertainties that creep in as a result of that. When we're looking at individual studies, we've then got randomized controlled trials, which again are often talked about as the gold standard of how to do, how to assess a technology. We're comparing one intervention with another in these via random assignment of similar groups of people to each. So we're starting off with a pool of similar people, and we're randomly giving them one technology, one treatment, or the other. And the reason we assign people randomly is to try and minimize as much bias as we possibly can, and give us two comparable groups that we can go away and say, well, these people are all the same to start with. We've allocated them out completely at random to minimize bias, and then look at, is the effect we're seeing truly down to the technology we're assessing? But it's really important to emphasize that RCTs aren't practical or possible for a lot of treatments, and there's a lot of good ways of doing observational studies as well. This is a kind of observational studies is a catch-all term that's often used to describe any study at all that is done without randomization, really, anything other than a randomized trial. it's any way of observing what happens to patients over a specified time period. That could be done prospectively through something like a cohort study, or it could be done retrospectively through something like a case control study. And as I've said there are many more types. And one of the challenges in our field is sometimes trying to just to classify these. Really important to emphasize in health technology assessment as well, without an appropriate control arm, in other words, without that comparison to standard care or some other useful treatment, studies that don't do this and don't have a control arm make it very challenging to interpret and use those studies in HTA. It's not impossible, but it does become much more challenging and bring in more uncertainty. Okay. Once we've assessed all the evidence, we've gathered all the evidence, we've assessed all the evidence, we then do something called evidence synthesis, which is, as it says, pulling together all of the evidence. What does it tell us, and with what certainty from our critical appraisal that we've done? And we do this for each outcome we're interested in. There might be 5 or 6 different outcomes that we're interested in. Evidence synthesis can mean formal statistical analysis using something like meta-analysis, but there are other ways of doing this as well as meta-analysis, but that may be the one that you've most commonly heard of. Any method of formal statistical synthesis that can be used to take results from several studies and combine them into one result in a statistically meaningful way. Where it's not possible to do that, or where it's not appropriate to do that because the studies don't allow it, we use something called narrative synthesis, which again is quite a wide term, which is basically encompassing any other way of categorizing everything, but hopefully still doing that in a systematic and useful way. This could be through any or all of these in combination, through just writing up results in the text in a structured way, but also increasingly through things like tables, matrices, and infographics. Okay, so again, in Health Technology Wales, our output is called an evidence appraisal report. But again, I'm using this just as an example. But again, the methods are applicable to other HTA bodies as well. So our evidence appraisal reports, these are much bigger reports than our topic explorations I talked about earlier. They run into 50, maybe 100 pages long. They summarize all the evidence we find on effectiveness, cost implications, and any economic analysis done to support that, and those patient and organizational issues that I described earlier. As I talked about earlier, every HTA body works with interdisciplinary groups that help them make decisions then based on all the evidence that's been gathered. And the first of those that I'm going to talk about very briefly is our assessment group. They review our evidence appraisal reports and give us feedback on those, and we talk through any issues and any changes that might need to be made. They're then sent out to stakeholders for external consultation. And when all that evidence and comments are gathered from stakeholders, we go back through that process and review all those with assessment group, make any changes that are needed, and then they sign off on the report. So if that all goes to plan and we think it's appropriate, we then produce guidance on the technology that we have assessed. So that brings in our second main decision-making body, who are Health Technology Wales appraisal panel. As with AG, as it says here, they're independent of Health Technology Wales, but work alongside us. And their primary function is to make a decision and produce guidance on the technology that we've brought them evidence about. And here is an example on the right-hand side, which is just the first page of our guidance on continuous glucose monitoring in pregnant women. And just to read the top line out there, as this says, the case for adopting continuous glucose monitoring in pregnant women with type 1 diabetes is supported by the evidence. Coming back to our value proposition, we did find that it was the case that compared to what was done at the moment, compared to standard care, we did find good evidence that continuous glucose monitoring used during pregnancy by women with type 1 diabetes results in them having better glucose outcomes and better control of their diabetes. And we also found that their babies did better after birth and were less likely to need intensive care stay. And therefore, we were able to do economic analysis that showed that that would result in cost savings if you introduced giving women continuous glucose monitoring rather than relying on other methods of glucose monitoring. The link there at the bottom of the page is a link to all the documentation on this example that I've gone through on continuous glucose monitoring. So if you want more information, you can go there and have a look at all these documents for yourself. Okay, so to sum up, I've hopefully told you about how health and care technologies encompass a wide range of interventions, such as diagnostics, ways of working, service improvements, the list goes on. We use health technology assessment to assess those, and that's a systematic and transparent way of assessing the benefits and the costs and any disadvantages of introducing a new technology, using the best available evidence that we have and gathering that evidence in a systematic way. In terms of gathering that evidence and assessing this, there are many different methods of doing this that I've just touched on very briefly. And there are also many types of evidence that we need to consider, and their rigor and their certainty varies. And these are all the kind of trade-offs that we need to go through, again, in making a decision on how a technology should be used. As I've hopefully described, Health Technology Wales use health technology assessment to produce reports and guidance on a wide range of health and care technologies. And there's a link there to our library where there's about 30 or 40 pieces of full appraisals with guidance, and many more, something like 200 of our shorter topic exploration reports that you can browse if you'd like more examples of these. Diolch yn fawr, thank you very much. These are our contact details. You can use the email address there to get in touch if you have any questions, and please do have a look at our website and follow us on social media.